I couldn't see.
Doesn't matter, Omar. We'll just go through the slides, and we all know what you look like. You
Somehow
look
I
very
don't
nice.
see myself in here. Sorry about that. Sorry about that. But that's fine. So um, when we talk about Antegrade techniques, mostly we can mention as single wire technique. We can cross CTO with single wire, or step up or step down escalation or de-escalation technique, and also we can do parallel wire technique. This is also, I think, currently we can use as a best practice, at least in some part of the world. And iOS guided entry or re-entry is, I think, very important for integrated approach, because sometimes we can't see proximal cap, and iOS is extremely helpful. iOS can show us exactly where is the cap, and also dissection re-entry integrated technique is, I think, very valuable, and in some cases must-do technique. So this is algorithm according to CTO Club, and we start if we have a good distal landing zone, we can try integrate. If you don't have any distal landing zone or very long CTO, we had better turn to red velvet approach. So which kind of wire we can use? I don't want to go more detail because we will talk about tomorrow also. If we have a macro channel, we can use hydrophilic wires. We can use pilot series, XTA, RSU, Black. These days, Gladius EX is very nice wire. If we want to go intra-plug, intra-plug, then we can use Gaia series, Judo series, Ultimate Bros, Miracles, Conquest, Hornet 14. If we like to go subintimal, sometimes if you have classified vision, we do subintimal tracking. In that case, Fielder XT Pilot 200 and Gladius MG is very nice wire these days. So in this presentation, I like to focus mostly 2 steps: proximal cap penetration and wiring CTO and reach the true lumen. So I'd like to show you an example. This is RCA occlusion, and occlusion is right at the RV branch. From here, it looks like this is ambiguous cap, and someone may ask IVOS to go antegrade. But if you go from right oblique view, in here, I think all of us agree where is the proximal cap, because obviously right branches has superior takeoff. So now I know where should I go at least. If I know where I could go, we can't tell it ambiguous cap. Ambiguous cap, we have to in puzzle. We shouldn't. In that case, we don't know where we should go. But here, I think we can go straight. This is dual injection. Shows me this is not that long vision, and in this case, the first wire was Gaia second, and you see that Gaia second find the proximal cap, penetrated it, and it goes slowly. If it goes, I never stop. I goes until wire stop itself, right? Because it shows me that the wire find a loose tissue and goes nicely. So as you see, I crossed all lesion with one movement. If I stop or if I try to insert my microcatheter, I may lose that loose tissue. So I suggest you to go in one. If wire stop, then of course you can take a breath. You can move your microcatheter more distal and continue. So in here, why I choose Gaia rather than hydrophilic wire? Because I have a side branch. If I most probably, if I have any hydrophilic wire, it will go directly side branch rather than proximal cap. So we crossed it. Of course, we did contrast injection to make sure I am in the true lumen. We have to do it all the way, all the time, right? So I am happy. And from here, I have to check Gaia second. wire to workhorse wire. This is very important. We never work over stiff wire, CTO wires, and do dilatations, and this is the final result after implantation stance. So let me show you another Antegrade CTO case. This is again LED CTO. We have a very short left main, and this is the CTO. And here I have a little bit question about where is the proximal cap. It could be either here or here. In here, I was helped me a lot. Yes, to be honest with you. So from other view, still I'm not sure where is the proximal cap. We have a nice diagonal, and this is EBU catheter, and EBU always goes to circ, and I like to go LED. In that case, I pull, after wiring CX, I pull my guiding, and then try to redirect my wire to LED. Sometimes we need to do this maneuver.
Omar, we have 4 more minutes.
Sorry?
We have 4 more minutes, and then...
all right. So let's go fast. Yeah, okay. So, and here, I did the use I was here. The first I thought proximal cap was here, but when I try to wire it, my wire goes along this vessel. So then I realized that proximal cap is here, and I redirected. I pulled back and redirected. And this is also Gaia Conquest Pro, and it crossed lesion. So after stanting, LEDs looks like that. I'd like to show you another case regarding wire escalation and escalation. This is LED CTO again. You see, after diagonal LED is occluded. Regarding choosing wire, I think, again, bilateral injection is like that. So in here, first we have ultimate miracle trigram. And this is also a wire that can go easily side branch. As you see here, it goes touch proximal cap, but just jump to side branch all the time. So if we try it 10 times, most of the time it will do the same thing. And then after 1 or 2 minutes, we change this wire to Conquest. And please look at how Conquest behave in this proximal cap. Conquest, if it is find the proximal cap, just penetrated it and goes directly to the distal. Now I penetrated. We are in this CTO. It went well, but after that, I see that it is in subintima. What I did after that, I pushed my microcatheter into the CTO and I pull back Conquest because it's subintima. And Gaia second, I send after that Gaia second, and Gaia second easily find the true lumen. So we did escalation and escalation in this case. After. So this is a case for step-down technique. We have RCA mid CTO. Dual injection shows me this is not that long lesion, but we have some tortuosity. Again, we have a tapered proximal cap. And first wire was here a Gaia third, and microcatheter was fine cross. And you see that Gaia third crossed the CTO in this way and went somewhere here. I feel it looks okay to me. But after dual injection, what we have, we are in the side branch. So we have a curve here, and the Gaia has to take that curve, but Gaia is stiff wire. Will be not easy to do this. I tried a little bit, I failed, and after that I changed my wire to Gaia to Pilot 200, and that one, after one or two trial, still side branch, and now find a way. So this is obviously step down technique. We can use this technique as well. So for proximal cap penetration difficulties, we can increase our...
Omar, some really great cases, but the time's really like we're beyond time. So maybe some 1 or 2 minutes to some quick remarks and very short time.
So let me show you one parallel wire technique, which is I think quite useful. This shows that case, and I'd like to finish with this case. This is another LAD CTO case. This is antegrade injection. With bilateral injection, seems that not that difficult case, right? We have a channel. It shouldn't be that difficult to wire with hydrophilic wire. In bilateral injection, we have obviously channel. Maybe here we have a very small CTO. And unfortunately, the wire could find that channel and run sensible space here. And that case, we had better use another wire, and the second wire should be 1 or 2 millimeter left side of the first wire. And now I have the advantage of the parallel wire technique. Now I know where should I go exactly. 1 or 2 millimeter this side will bring me the actually true lumen. And here you see I'm just above the distal cap, and then I was able to cross the LAD. So this is the final result for LAD diagonal. So thank you very much for attention and patience.
Thank you, Omar. That was really wonderful.
And I'd like to see you tomorrow, all of you.
Yeah, we look forward to seeing you tomorrow. The very skillfully done. We love the cases and wire control you have, the choice of wires. We'll interact with you more as you come tomorrow. So thank you very much. And
thank you.
And for Omar. And we loved your lecture. And for the final lecture of the day, we'll have Dr. Emmanuel Brelakis. Is Dr. Emmanuel online?
He has a recorded
It's a recorded lecture. We're going to have it now.
Institute, and it is my great pleasure to present for the Pakistan Live 2023 meeting on the management of complications of chronic total occlusion interventions. These are my disclosures, and this is an overview of the complications that can happen, both inside the heart, but also outside the heart. Complications are part of the interventional procedure, especially CTO-PCI, where the risk of complications is higher. And the way to approach them is by thinking about them both before, during, and after every procedure. What to do before every procedure? It is important to know what actually can go wrong, what are the potential causes of complications, and what to do if a complication occurs. And complications, as mentioned before, can happen both in the coronary tree, and since coronaries are essentially pipes with blood flowing through them, what can happen is having the pipe close, having the pipe rupture, have a perforation, or losing equipment in the coronary vasculature. What can happen outside the coronary but still inside the heart is hypotension, myocardial infarction, arrhythmias, and tamponade, and these typically result from one of the three main categories of complications. But we can also have problems outside the heart, in the access site, thromboembolic complications, complications related to contrast, and radiation-related complications. How to learn about approaching complications happens through many routes, through books, journals, attending courses such as this one, proctoring, doing cases, participating in a community, and keeping track of what is going on. And one of the things that can go wrong during CTO PCI that can be devastating is actually occlusion of the donor vessel. This is a patient with an RCA CTO, filling with the left supplying the right coronary artery. We ended up going retrograde, but during the procedure, while we had placed stent in the right coronary artery, the patient developed bradycardia and ST segment depression that got worse, and then eventually the patient had ventricular fibrillation. We ended up having to put the patient on ECMO, and this was the problem. The patient had dissection in the left main. This was treated, and then the patient eventually had a good recovery. But this reminds us of the importance of the donor vessel, and acute vessel closure can be a devastating complication of CTO PCI, which is why a safety wire should be inserted in the donor vessel before doing CTO intervention. Moving on to the second major category of complications, which is perforation. We have now a classification based on CTO arc that not only accounts for severity, which is done based on the Ellis score, with 3 being the worst severity of complication, but also based on the location. And the location is critical because it determines treatment. Specifically, when we have a large vessel perforation, treatment is with covered stents, whereas when we have a distal vessel perforation or collateral perforation, the treatment is usually using coils or fat embolization. For every complication, such as perforation, it is important to have an algorithm in mind. For example, for perforations, the first and most important step is to inflate a balloon to occlude the vessel, give fluids, do pericardiocentesis if the patient develops tamponade, and call the surgeons. And then, if we have a large vessel perforation, typically we put a covered stent. If we have a distal vessel, we do embolization. We do not reverse anticoagulation because that can lead to thrombosis, and this is reserved until after all the equipment is removed from the body. And very rarely, surgery might be needed to control a perforation. This is how pulsus paradoxus looks like, how I can prove this to you, because this is the waveform after we drain the pericardial effusion in a patient with perforation. We have more than 20 millimeter mercury drop in systolic pressure. This is pulsus paradoxus, that is a precursor of tamponade. How to take care of perforation? When we have a large vessel perforation, the treatment can be through a single guide or through 2 guides. If we have a large guide, we can deliver a covered stent and a blocking balloon through the same guide. So insert 1 wire, put a blocking balloon, deflate the balloon for a second and get a second wire down. And then we get a covered stent right proximal to the perforation site, deflate the balloon, get the covered stent quickly in, inflate the covered stent, and that causes hemostasis. But sometimes if we have a smaller guide, this may not all be feasible through the same guide. And that's when we do the ping-pong technique, in which we first inflate a balloon to stop the bleeding. Then we pull back the guide catheter. We engage with the second guide catheter. Once again, advance the second guide wire, get a second cover stent in place, remove the blocking balloon, deploy the cover stent, and achieve hemostasis. Another way in CTOs to take care of this complication is to actually use dissection and reentry. So this is an example of a perforation. If we do dissection reentry, either antegrade or retrograde, then one can use a tissue flap, create a tissue flap that then seals off the perforation. How about distal vessel or collateral perforations? These are treated with coil or fat embolization, which have advantages and disadvantages. The coils are very visible, but are expensive and not available in all cath labs, whereas fat is universally available without any cost. But the problem with the fat is that we cannot see it, and that is why we dip it into contrast. Another problem with fat is that it can be difficult to load it because it tends to float and tends to fall off the microcatheter. So one way to actually achieve hemostasis is to turn it upside down and then use a small syringe to inject the fat all the way to the perforation site. How can you do this? We typically use the so-called block and deliver technique. We put a balloon up, then similar to the large vessel perforation, deflate the balloon, get a second wire down, then get a microcatheter. And then the microcatheter is used both to inject contrast to see if we have achieved sealing, but also to deliver either fat or coils to the site of perforation and then achieve sealing of the perforation. If we are not certain whether we have achieved sealing, one can give echo contrast, and if there are no bubbles going in the pericardial space, this is good. But if, as in this case, we see bubbles, that means that we have not sealed the perforation. Another way to seal a small vessel perforation is to actually place a cover stent across the origin of the perforation. And the beauty of having these techniques is that they apply in multiple settings, and including CTO PCI, for example, if we have an epicardial collateral perforation, then we typically want to close it from both sides, otherwise we may have bleeding through either of the collateral vessels. So this is one example when closing with coils or fat from both sides may be important. Also, for perforation, it is important to remember that in the previous bypass patient, one can have loculated effusions form, and this can be lethal and may require surgery or CT guide drainage. So if we see a perforation in a bypass patient, we need to act very quickly and seal the perforation very quickly. And also we'll mention a few words about equipment loss and entrapment, since this can happen in CTO PCI. The mechanism of loss is typically through deformation of the stent that we try to advance through a poorly prepared vessel. Then you are unable to deliver the stent, try to pull it back, and the stent is deformed and it's spilled off the delivery balloon. If that happens, don't forget that one option is to leave it there and either deploy it or crush it instead of making attempts to retrieve it. And actually this approach to deploy or crush may be faster and safer than actually trying to take it out. If, however, it's in a sensitive location, then one may have to take it out, and the way to take it out is use various techniques such as a small balloon technique, a snare, or various guide wires. And this is an example of crushing the stent. The stent is left in place, another wire is advanced next to it, balloon, and then get a new stent and essentially exclude the lost stent from the circulation using a new stent. The small balloon, that's the simplest technique for retrieving a lost stent. Push the small balloon through, inflate it, pull it back, and then sometimes this will come through. Sometimes, however, the stent may be so deformed that it may not be able to pull it back into the guide catheter. Snares can also help, but be careful because if you pull too hard, you might actually injure the coronary vessel, and it is important to have those snares available in the cath lab. Things can be lost, are not just stents, but guide wires can be lost. Once again, similar to stents, one can either leave it in place or one may try to take it out. Sometimes leaving it in place and putting a stent over it may be the safest and fastest way to deal with this complication. So a lot of equipment is needed when we try to tackle complications. And that is why it is important to know this equipment before you actually need it. For example, the coils and the cover stents, it is important to know how to deliver them before the complication happens. Also, it is important to start with easier cases and then do more complex techniques and more complex cases as you gather more experience in your CTO PCI armamentarium. The other thing we can do is to be very knowledgeable about the angiogram and the patient. Understand the indication, understand the anatomy, what we can do if something goes wrong. What to do during the case is to don't do very difficult and very potentially risky things unless those risks are counterbalanced by significant anticipated benefit. For example, this very complex epicardial collateral may not be worth tackling in a patient who has only mild angina, but may be well worthwhile in a patient who has severe class 4 angina. And then it is important to be very focused and alert during the case, so if a complication happens, it can be detected and treated very soon. The reason is, if something goes wrong and you take care of it early, you can shift the severity of the complication to the left. You may have no much consequence, but if you don't, then this can progress to require things like emergency bypass, cause a stroke, lose a limb, or even cause death. So being focused is key to this early diagnosis. Focusing on the patient, on the hemodynamics, on the location of equipment in the screen. Keeping track of all these moving targets throughout the case ensures prompt recognition and treatment of any complication. And also this requires fast movement from the various stages of loss, understanding what went wrong, and then accepting that it has happened and trying to find ways to treat it. So what to do if the complication actually happens? The first thing is to call for help. This is self-evident. If the patient has cardiac arrest, we'll call a code. But even if not, even if the patient is not in extremis yet, it's cool to call for more operators to help you with the steps. Also, it is important to manage our stress level. Being panicky and disorganized will make the whole team go out of control. Stress is good up to a certain level, but if the stress is too much, then performance suffers. So it is important to be calm, in control of the situation, kind to the team, and open to communication, because often people will see more things than the operator can appreciate. Manage yourself and also follow different steps, follow the algorithm, such as the perforation algorithm that we discussed before. But things don't end after the case ends. It is important to reflect on what happened and what is the learning from this case and this complication, and how can it be used to prevent or treat future complications. Because the reality is, what happened in one case, the after for one case, is the before for the next case, and this is also the before for the following case. So everything we do is in a circle. There are no finish lines, but every case is a beginning and an end in itself. It is important to understand what happened, so have debriefing sessions, understand what we did right and what we would have done better. And this can happen through teaching with the team, talking to the team, talking to other operators. And while we hold ourselves to high standards, we also want to be compassionate and grateful for what we're able to achieve. So the process of preventing and treating complications happens before, during, and after every single case. And the bottom line is that understanding the potential things that can go wrong can help you prevent them. Understanding and knowing what to do if it happens helps you treat them fast without losing time. Being alert helps you see if something goes wrong quickly, so you can act quickly and minimize its consequences. And then asking for help is important, keeping calm, communicating with the team, but also don't forget to learn what each complication has to teach each one of us. Thank you.
Okay, that was recording, but it was a real great lecture, and I think we learned a lot. So I think we're going to reassemble here at 2:30. There's lunch for the faculty in the place where we had breakfast. Naam kya us restaurant ka? Dastarkhan. Yeah, Dastarkhan. That's where the faculty going to have, and for everybody else and all the participants, they just go left and then right, and there's Shamiana there, and lunch waiting for you there. And we, inshallah, reassemble at 2:30. And Dr. Salman Orian's lectures due. We'll have all that in the next session. And thank you, everybody, for the patience and being here. Wonderful having you. Great. Thank you. A big hand for everybody.